partner and mentor, is going to give us a lecture. Can you hit the next slide there, Linda? Oh, before that, just to introduce our faculty again, Dr. Dimar will be giving our lecture today. Next slide. And Dr. Steve Glassman is here also to help with our panel discussion at the end. Just a quick overview of our program. Dr. Dimar is going to start us off with a short 15-minute lecture. And then our fellows, I'll introduce each one by one. We'll go through 4 cases. Our topic, again, is thoracolumbar trauma today, especially fracture dislocations. We're going to kind of focus on those. And then we'll have, hopefully, at 5:50, leave 10 minutes left for a quick panel discussion and some questions and answers. If you guys send questions into the chat room, I'll do my best to try and keep up with them and respond in the chat room as well. So without further ado, Dr. Dimar.
Okay, let me try to share this here. Okay. Move this down here. Full screen. All right, can you see me there? Are we good?
We're not seeing the full presentation.
You are?
Just seeing your, we're not. We're seeing your Finder.
It says we're screen sharing here.
Yep.
Click on the document.
There you go.
You got it, John.
Great.
Okay, good. My name is John Dimar. I'm one of the faculty at Leatherman. Been here a long time. I'm going to talk to you about fracture dislocations, which is kind of a favorite topic of ours. And there's not just one type. I want to point that out. Here's my disclosures. There's a lot of classification systems, and you can see every generation of orthopedic spine surgeons have come up with their own classification. It lasts about 10 or 15 years, and somebody comes up with a new one and reinvents it. First guy really to talk about fracture dislocations was Böhler, of the Böhler clamp in Austria. And he actually described a lot of different spinal injury fracture patterns. And then, of course, Watson Jones was one of the first guys really to kind of operate on it. He came up with 7 fracture types in the 60s, 50s, and 60s. And again, fracture dislocations were included in that. Sir Frank Holsworth also developed the 2-column injury model that we talk about a lot. He also included the flexion rotation and flexion distraction kind of injuries and dislocations that we talk about in 1970, and published that and talked about the 2-column. And then, of course, our recently departed Francis Denis, who came up with the 3-column injury and also talked about fracture dislocations. All of these gentlemen said that generally these need to be operated on or stabilized in some fashion. Now, the young pup in the group, of course, is Alex Vaquero, who I helped work with on the TGLIX algorithm, if you know about that. It's the first one really to include neurological injury, which is very important in these kind of injuries because there's a high prevalence of neurological injuries when you have this, and added the MRI and added the ASIA scale and came up with a really nice kind of simplistic way you can do this. And it's been basically the morphology. It's a point system. I won't go into a lot of detail with it. Needless to say that most fracture dislocations are kind of at the upper end of the scale or off the scale and will need to have surgery. Here's just kind of a nomogram real quick that you can look at to show how you score it with the posterior ligamentous injury, the neurological status, and of course the mechanism of injury. Now, not being content with this, he came out with another system and combined it with the AO Swiss system, which is relatively complicated. And I generally don't think about this myself personally, but you're more than welcome to take a look at it. And it actually kind of melds Magarel's system, the AO Swiss system, with his system and everything. And it's a little bit difficult to score these, in my opinion. Maybe I'm just a little too dumb for it, but it takes a little bit more time. When you look at this, there's a couple other scoring systems specifically for fracture dislocations. One by Kana that talks about 3 different kinds, really 4, 3A and B. Another system that really looks specifically at fracture dislocations. There's another paper by Chosky that looks at this. He looked at 50 patients. Most of them were lower grade fracture dislocations. A lot of them are neurologically intact. And of course, he just basically looked at them, and you can see a lot of them are Asia A, as you would expect with this kind of injury. It's not often that you get them that you can recover them completely. And this is an interesting article that's recently been published you might look at that looks at the AO type C injuries, which are the fracture dislocations. And it talks about 5 different techniques to reduce them. That we're going to show you some of these techniques with some of the case presentations that you see here. And you can take a little bit of time and look at this paper too if you want to and go back and get the reference. But basically, there's a whole variety of them. And there's a lot of different ways you can reduce them by rods, by brute force, by unlocking the facets. And we'll try to show you some of those briefly, and you can do them. Now, remember, injuries occur at different ages. Like at young people, you're going to see a lot more fracture dislocations. Kind of middle-aged people, you start getting more burst injuries. And of course, older people will get extension injuries because they're ankylosed, or Cummel's disease, or osteoporotic fracture. So fracture patterns, first of all, occur at different ages. Most fracture dislocations automatically are going to be high on the TLIC score and are going to need to have some sort of intervention on them. So here is a kind of a schematic that we published a few years ago, looking at all the different kinds of fracture dislocations. And there are a lot of different patterns that you can look at. Remember, there's 6 vectors of rotation, compression, side bending. All of these can result in slice fractures, burst fractures, chance fractures, extension injuries, and we'll kind of go through some fracture patterns. And then the fellows are going to present you some unknowns that you could think about how you would classify them. So here's a 32-year-old with a high-speed motor accident, a true fracture dislocation where the facets are jumped, all 3 columns are damaged. And really what happens is they get a profound flexion moment and the vertebrae slide out of position and slide back. Therefore, they have a fairly high incidence of neurological injury. And this is what they look like. You hate these when they come in at 3 o'clock in the morning on a Saturday night. And they're very, very difficult to treat. You have to unlock them. And there's always a chance of neurological injury. So we generally will take these to the OR and reduce them immediately as quick as we can. A lot of times they'll have an associated dural tear, but you may not necessarily get a CSF leak. So this is the most common kind of pattern you'll see. Now here's a 14-year-old girl that actually presents neurologically intact. And younger people may do better. And she had a 3-4 fracture, neurologically okay. And you can see here, she's got kind of a fracture dislocation with a combination of burst here. So it's kind of a 3-dimensional dislocation. You see the amount of swelling around it and everything. And you see this is a pretty bad fracture, but fortunately her canal is still open and she's neurologically intact. Highly dangerous case to reduce. And fortunately, one of my partners did this, so I didn't have to sweat it out on this. But you can see even on the MRI that the cord is tethered right over that posterior fragment. So this is something that you're going to take right to surgery and reduce. And we did, and she remained Asia E, and fortunately had no other problems. Now here's another example, a 30-year-old female with a rollover ATV accident and everything. She comes in and no seatbelt, no medical comorbidities. And she has more of a chance injury where she's broken right through the bony substance of the vertebrae itself. There's a lot of different patterns of this. Some of them involve ligamentous injury, but a classic GQ chance injury is like this, goes right through the bone and pedicle. Sometimes we'll tear the ligaments above. And here you can see it very nicely splitting the pedicle. And you want to reverse this injury, like reverse the injury directions and vectors and go back the other way in almost all the reduction maneuvers. And here's my crack squad of fellows doing this. And you can see things are all torn apart here all the way through the posterior. And we're going to tension band it with a little wire and bring it back into position and get a nice reduction. Just another kind of fracture dislocation. Now here's an 11-year-old. These are younger patients, and you're going to see pure ligamentous injuries. They often will present with some sort of neurological injury, but they almost always get better if you reduce them. So the classic injury is this. You just basically wrap yourself at L3 pivot point around a seatbelt, and they come in like this, and they tear everything all the way to the anterior lateral ligament a lot of times. And then they reduce, and they basically tear through the ligaments and the disc all the way to the AL, and then they'll spontaneously reduce, but usually they don't reduce all the way. So here's an example, one of our patients that was involved in a severe MVA, and you can see this isn't right. This patient is actually retrosthesis. The facets are sprung at L4-5, and you can see there's a problem going on here. So when you get a CAT scan, you can see how wide the facets are. This is a very unstable injury, and you're going to have to go in and fix this. The MRI shows psoas bleeding over there, bad injuries. But with kids, you always go right away, and you can see everything's torn in two on the left there, and we're going to fix this and stabilize it and reduce it. And this patient I actually still see and is doing really quite well. This is probably one of the more dangerous injuries and the more likely to have some sort of problem is a flexion rotation injury. And you get the upper torso will get twisted often in a car wreck or some sort of industrial accident. And what happens is not only do you tear all the posterior ligaments, but you rotate and tear the disc out and get a true three-dimensional rotational injury, as you see here. Another pattern you can see, here's an example of it. You can see on the axials on the right on the CT how the vertebrae are rotated off of one another. Very serious injury, neurologically not intact. The 3D shows the translation that often occurs with these also. And here you can see, quite honestly, the pleura. We're all the way to the pleura in the front. All the intercostals are torn, all the fascia is torn, and these can be very difficult injuries. So generally, we'll do temporary stabilization on these and then do a full pattern reduction. And we always fuse long, usually 3 levels above and below, because rotational flexion dislocation injuries are incredibly unstable, okay? So now we're going to add not just a dislocation, we're going to add compression to the injury. Remember, 6 vectors. And this person fell out of a tree. And here you're going to get significant crushing of the vertebrae below and perhaps a burst injury that may cause additional neurological injury. So again, in this case, you tear all the ligaments, usually a 2 or 3 column injury. And at the same time, you crush the vertebrae and sometimes rupture pulse fragments. So here's an example here. You can see how the ligaments are spread wide apart here. And you can see how it's torn all the way through to the posterior column and the subcutaneous blood. And here you can actually see the gapping in the torn ligaments of the PLC. And these, again, will demand probably a full pattern spread of at least 4 screws above and below, and we'll usually go 3 because you just can't take a chance. This person was neurologically fairly normal. Now, here's a really rare injury. This is a dislocation slice. You only see one of these about once every year or two, and you actually get a compression and a lateral thrust, and you'll split. And the key to it is always seeing the fracture line go through 2 vertebrae. And it happens essentially like this. And they're very, very unstable, and they require a longer fusion. And here you can nicely see it on this particular case where the fracture pattern goes through 3 discs, and then 2 discs and 3 vertebrae, both in the AP and the coronal and sagittal views. So you can really see how these develop. The CAT scan shows it really quite nicely on a white view. And you can see it also less effectively on the MRI, but the patient's neurologically intact here. So we're going to want to take him. In this case, this was a rare injury that we put hooks in a few years back, and the patient remained neurologically normal. The last thing we'll talk about is a little bit of hyperextension injuries. These occur in the older patients. They often will be neurologically intact, but occasionally they can be neurologically involved. This particular patient was involved in a really bad industrial injury, and not only did they extend backwards, but they rotated and translated. So it's really just where we knew how the patient got injured. They actually got bent backwards by a press and really kind of snapped in half here. And you can see they're translated, they're extended, a lot of injury here, translated off to the side, anterior listhesis, tough thing. And you can see how they're offset when we're going to do them. The key to these, of course, is placing your instrumentation to get a handle on the opposite ends of the fracture. That way you can put it back in position. This patient was neurologically intact, except for L5 nerve root avulsions. So we put the patient back in good position here and nicely reduce it after we got screws above and below and unlock the facet by doing a partial facet resection here. And this is the final x-ray of the patient. Unfortunately, we had to go to the sacrum on this. Now, this is a hyperextension dislocation injury, even worse, hit by an automobile, polytrauma. And here you actually can rotate all the way back. And I won't spend a lot of time on this because I know there's a case they're going to present, but usually it'll stop when the posterior spinous processes bump into each other. And when that happens, usually you're stable. But in this case, the patient has a fragment and some bursting component. And basically, we had to go ahead and just simply reduce it and do a longer fusion because he's relatively ankylosed. It won't make much difference. You can see he had polytrauma down there also, period. So often we'll see these patients and they'll quite honestly have combination injuries. And these make it even worse, longer fusions, longer time, more blood loss. So here's a guy that was involved in a very severe MVA. And not only did he have a T9 fracture, but he also had an L1 fracture. So he had a chance fracture with a severe burst injury. And so he had both of these patterns that you can see here on the left through the bone and on the right, a compression injury. So we basically can see them both here. You can see the chance injury above and the severe compression fracture with some dislocation. So both injuries will need to be stabilized simultaneously. You can see it better here on the CT scan. And you can see that, of course, this patient was neurologically Asia A. So we just basically did a long fusion to get a hold of all the problems and everything so that we could adequately treat him. So in conclusion, fracture dislocations come in a wide variety of patterns. You should always consider them unstable. They will always score very high on the TLIX. scale. Okay, and the different patterns require different strategies. Like some of them you're going to have to flex to reduce, like a hyperextension injury, and some of them you're going to have to reverse the injury if they're flexion dislocation injury and pull them back into position and reduce them. The vast majority of these will have a severe neurological injury, but occasionally you'll get somebody that's got an injury that is recoverable, like an age of B or C that may become a D or E, and those are the ones you want to get to very quickly. We have found that pedicle screw fixation probably imparts the most stability and allows you to do more three-dimensional rotation. Very rarely, you might have to go anteriorly and provide anterior support, but this is a rare event. So that's pretty much the 6 or 7 different fracture patterns that are rolled up in a classic fracture dislocation. So they're not all the same, and that's important. And we're going to show you some examples now. Thanks.
John, that was a wonderful presentation. Thank you. That was incredibly comprehensive. Really great. Really great. So now let's move on to our fellows. Our first presenter is Dr. Jeremy Thompson. He joined us this year after doing his residency at Mayo Clinic, and he's going to join the group at Ortho Carolina in Charlotte after the completion of his fellowship. So go ahead, Jeremy.
Thanks, Dr. Djurasovic. We'll start the presentations off with a 65-year-old male who fell about 14 feet from a roof while painting. He was initially evaluated in an outside hospital, but transferred to us with a thoracic spine fracture dislocation. On exam, he had present sensation to both legs, but it was abnormal throughout his left leg. His motor exam showed no movement, no motor strength to his left lower extremity, and he had some weakness on the right lower extremity, particularly 2 out of 5 strength to his iliopsoas and quad, and 3 out of 5 strength to his tibialis anterior, EHL, and gastroc. So we classified as an AJC, and this was an isolated injury. So on his presenting thoracic spine CT, you see this fracture here at T910. It's a fracture dislocation. It's kind of like a splice variant where there's a shear component in the coronal plane at T9 and extends to the T10 vertebral body. As you can see on the right and left sides, there's a fracture of the pars and the facets, and there's obvious translation there. This CT redemonstrates the fracture pattern. You see the fracture lines, the coronal plane, and the sagittal and the axial there. We did get an MRI, which showed that he had a core contusion at this level. You see the large amount of soft tissue injury, the disruption of the posterior ligamentous complex, and the associated stenosis at that level. So, in summary, we've got this patient with the T910 fracture dislocation whose age is C, the neurologic injury. Obviously, we would all agree that this is a surgical problem, but there's a lot of different ways you can go about it, whether you do an open reduction and fusion versus trying to take care of it perc. Number of levels are kind of controversial. Do you do laminectomies, use supplemental rods, or need anterior support? So we ended up taking the patient to the operating room rather urgently, and we were able to reduce him on the table without much manipulation. We just repositioned the bolsters. We were able to localize, and we treated him with a T6 to 12 open reduction, internal fixation, and fusion. We ended up planning on just the T9 laminectomy, but there was so much soft tissue injury that we extended the laminectomy up to T8 to find a normal plane, and then carried it down to T9. We did find a traumatic durotomy with some bone fragments and intruding into the canal. But when we removed those, we actually didn't find any CSF leakage. So that was just repaired and sealed. You see our intraop x-rays there. Our post-op x-rays show our final construct. We went 3 up and 3 down. We have 5 points of fixations across the fracture. We did get a CT scan that shows that the fracture is well reduced, that translation is improved, and the canal is relatively open. And this actual view does show the significant comminution in the posterior elements and through the vertebral body. So the patient actually did improve. We got to him pretty quickly and decompressed him. He went from age of C to age of D. His strength on his right lower extremity went back to full strength, and on the left side, he did regain some strength, but only the gastrocs went to at least anti-gravity. So this is our case, a T910 fracture dislocation. We treated with a T6 to 12 open reduction internal fixation infusion with T8 and 9 laminectomies.
Great job, Jeremy. Thank you. Yeah, I mean, that's, and it's those patients with incomplete injuries where I think you can really make a big difference in the patient's quality of life. So, yeah, we definitely trying to get them back urgently, but, sometimes one thing we didn't talk about is how often these patients have abdominal injuries, chest injuries, et cetera. So, yeah. All right. So, great job, Jeremy.
I just had one question. Tizzy Lieberman. You did the MRI scan on this patient before taking him to the OR. What's the value? How did that help in the decision making?
Jeremy, you want to comment on it?
Yeah, so I think an MRI would just further classify the neurologic injury. I think there's the obvious bony injury, and we're going to have to treat the fracture and the instability, but knowing that there's a neurologic injury, we know that could change our plan as far as where we do laminectomies. If we're looking at something that would change our surgical plan. Thankfully, the radiology department at the hospital that we take trauma usually has an MRI available that we can get to pretty quickly, even for things not as urgent as this. So we were in a good situation where we can get these things done urgently as we're getting ready for the OR.
I think what Jeremy said is key in that if you don't have the capability to get it done quickly and not delay your case, then I think you shouldn't be doing it in a case like this. Then I think getting back to the OR expeditiously is more important.
Yeah, I think that there are papers that talk about the prognosticness, so to speak, of the contusion and the penumbra around it and how far it goes up and down the canal. I think it's useful in predicting recovery potentially. I also think it's useful from the medical legal standpoint to prove that there is a contusion pre-existing, to say that the patient was definitively neurologically involved if there's ever a question of that. And I think you can also identify things like epidural hematomas that are extending up and down the canal. And if you have the capability, like we do at our university, to get it, within right out of the emergency room on the way to the OR, I think it's probably worthwhile. If I don't have one, then I would just reduce it and clear the canal, with visual inspection.
This is Jackson. A quick question on the nightmare scenario, the circumferentially unstable patient who's neurologically intact or has function. You guys are taking them to the OR in the middle of the night urgently. Do you monitor? Do you have spinal cord monitoring available to you or not?
Yes, it is.
That's great. Good
It's usually
resource.
negative. Then we let them go home. But yes.
John, it's Neil.
Yeah. Hey, Neil.
John, it's Neil. Quick question. So, do you guys have an OM in the hospital?
Absolutely.
So, one thing we started doing, I think, just using enabling technology. Right, did a great job. Reduce him. It's all reduced on table. Percutaneous fixation, and the thought of doing an OM spin at that point to make sure you got a really good reduction. But if you did, you may not need to do anything open to reduce that fracture, right? Then the only question arises, do you need to drain the epidural hematoma? The reason being, I think we avoid that traumatic durotomy and the mess that results once you get in there. It's just a thought. I've only done 2 of those, so I can't talk too much about it. You guys got far more experience. But I think with the OM, that part has sort of changed a little bit of what I would routinely go and open these people up.
Neil, I do agree that having the ORM's helpful. I think seeing the alignment's helpful. But the reality is these people are almost always going to have some deficit afterwards. And you're always going to be left with the question, if I decompress them, would I have made some subsequent improvement? So,
Right.
I think it's hard in that kind of scenario with an incomplete deficit. I think you're just better off doing the decompression and you've done what you need to do, because they're very unlikely regardless to come back to normal. And then you're left with the question, do I need to go back and do more?
Fair enough.
Yeah, and also, Neil, when you open these up, you generally, with a true fracture dislocation, when it's reduced.
But that's true. But the nightmare, the dural tear, the dome was popping out, the things are messy. That's
And
all.
it's
Just a thought.
interesting, they rarely get dural leaks too, because I think they drain all their CSF out circumferentially, and then they clot off, and it's unusual really to get a CSF leak, even though you may have a dural tear. Here we go.
All right. Well, our next presenter, great job, Jeremy. Thank you. Our next presenter is Dr. Amer Ahmad. He's our international fellow this year. He's from Jordan, and he's going to be continuing his training with another fellowship at University of Kentucky next year. Amer, go ahead.
Can you have the microphone?
Yes.
I left your piece with it.
I think you are muted.
Hello? Yeah. Can everybody hear me?
Yep, you sound good now.
Yep.
Yes.
Okay. Yeah. Right. So I'm going to present the second case for this night. It's an 18-year-old male who was involved in a motorcycle versus car accident. He was brought to the ED with an isolated spine injury. Upon examination, he has a 0/5 muscle strength in the bilateral lower legs with a loss of sensation. So he was basically classified as an Asia A spinal cord injury. He was a healthy with no medical issues, except for he was a smoker. So spine trauma service was consulted with that patient at that night. CAT scan was done with that patient, and basically it showed, excuse me. Sorry. Yeah. It showed T12L1 fracture dislocation at the sagittal view, and you can see on the axial how it's the comminution of the posterior element at that level with a severe canal stenosis with a retropulsion of that bone element. And again, you can see the MRI was done on that patient also, and it showed how the spinal cord was tethered at that level with a contusion and posterior ligamentous complex interruption. So he was basically cleared by the general surgery, and he was brought to the ER for surgery. We took an X-ray for him after positioning on the Jackson table, and you can see how the fracture is almost reduced on that just by positioning on that table. Then we did the midline approach on that patient, and upon exposure, we saw how the posterior ligamentous complex was disrupted with dural tear was found during the procedure. So basically, we did reduction. We used one of the maneuvers for reduction, which is you can see in the middle picture, using the interlaminar spreader. And another one was done later by using the rods. So, so if you want to talk about the steps of reduction in such cases, you have plenty of them. One is like simply reduction by gentle maneuvering and positioning on the Jackson table. If you have a soft tissue interposition between the fractures, like ligaments or a bony injury, bony pieces, you can remove these tissues to try to reduce these fractures, especially if they are hooked up between the facet joints. You can do, we did in that case a small bilateral laminectomies to allow for closing down that dislocation from the posterior. And of course, we use the rod as a method for reduction and fusion at the fixation at the end. So here's the final construct of that. After finishing the procedure, we typically fuse the 3 levels above and 2 levels below from T10 to L2, L3 with the 4 rods. Basically, it gives the construct more strength and to the extent rotation stability for that injury. And we did the final X-ray, AP and lateral, intraoperatively show how the fracture is nicely reduced and fixed 3 levels above and 2 levels below with the 4 rods. The patient was improved. He was at the presentation Asia 8. Then 3 months later, he was like regaining some sensation and start to convert from Asia A to Asia B. And here's another follow-up X-ray after 1 year of surgery, show that the final construct is still in place and still the fracture is in this place and reduced leads in a good way. Thank you.
Great job, Amir. Amir and maybe John and Steve, maybe if you can comment a little bit on how you guys, on trauma cases, how you make the decision to do a 2-rod versus a 4-rod construct, what goes into that thought process?
John, you're muted.
John, I think you're on mute still.
How about now?
Yep. You're back.
Okay, good. You know, I did that was a young patient with very good bones, so I wanted to go try to get a really good construct above and below. And that patient was really ripped in two. And when you have both a coronal instability, translation, you have anterior listhesis, you'll have posterior listhesis. Doing a double rod widens the construct, and it really it helps with rotation tremendously. It also is very, very powerful in flexion and extension and side bending because it's an outrigger that really prevents that a lot. And so this particular patient was, you could literally move both sides of the spine above and below the fracture. It was very, very unstable. You can add the outriggers and really stiffen that rod by, you almost increase it like 50-60% as far as rotational and flexion extension strength. I think when we tested that in the lab, those 4-bar constructs, and it really made me feel better. I didn't have to use a crosslink. And that's why on that particular patient, I went with a 4-rod construct. And it was kind of fun to do, quite honestly. It's very quick and easy. Very quick and easy to apply those. It takes you 10 minutes. And you get a lot of biomechanical stability.
Great. All right, thank you, Amir. And our next presenter is Dr. Kyle Kessler. Kyle joined us after doing his residency at University of Iowa, and he is going to practice in Chattanooga, Tennessee, at the center at the Center for Sports Medicine and Orthopedics in Chattanooga with one of our other fellows, Ben Geddes. So go ahead, Kyle. Let's hear it.
Perfect. Are you seeing my screen yet, or do I need to switch it over?
Yes, we see it.
Perfect.
Yep, you're good.
All right. So the case I'm presenting is a little bit similar to the one that Amir just presented, but kind of has a different flavor to it. And I'll point out some things along the way that we thought were interesting and worth discussing. So this is a 30-year-old male. He was involved in an MBA. He was on amphetamines. He came into our hospital. He was neurovascularly intact at our level 1 trauma center. And his only complaint was severe thoracolumbar back pain. At the time, going through his notes and things, it wasn't clear whether he was wearing a seatbelt, but you'll see from the images here, this looks to be an injury that has a very large flexion component to it. So we deemed this kind of a variant of a chance injury. When you look at that third sagittal image over from counting from left to right, has a bony chance type injury through that anterior body. But when you look at that coronal image on the far left-hand side there, you can see there's a vertical shear component to it, showing that it at least has some degree of a rotational component, but the primary mechanism we deem type of a flexion type injury. So that chance injury exits there through L1, and then you can see where T12 has some anterior listhesis on L1. where the posterior elements have been fractured and essentially unhooked and allowing T12 to slide forward through there. It's through all three columns. And in that way, it's similar to the one Amir showed, but not near as much translation or enterolisthesis of 12 on 1. And that's likely why this guy was neurologically intact. He was an Asia E compared to the Asia A that Amir had just shown. So like we kind of discussed previously, our trauma hospital is pretty good about getting MRIs. They happen quite frequently. On this, you can see they ran a quick sequence, a quick protocol through the MRI scanner. So the quality of the images is fairly low, but I included this in here just so you can see the exiting elements through the back. And then if you look at that far image on the right-hand side, you can see an intensity kind of on top of the fascia there with some of these things we'll show here in a minute. You can see why I'm pointing that out. The other thing that's notable on this injury that you can see here on this axial is it was basically at his conus level. He was intact, but he was at a pretty dangerous position here. So we positioned this patient as well on a Jackson table. With this injury being a flexion type injury, the biggest thing we wanted to do was close down those posterior elements. So when we positioned him, we put the ASIS pads somewhat low. We put the chest pads a little on the high side and kind of let him sag down into the Jackson frame, which essentially closed down those posterior elements, took out that bit of kyphosis. And you can see right there, 12 on 1 still has that enterolisthesis that we'll address here in just a minute. We'll see how well this plays. I don't know if you guys can see the movement of the video here. It might be laggy through the internet connection. Is that playing on your end?
Yeah, it's good.
All right. So as soon as we made skin incision on this patient, you can see just as soon as we go through the skin, you can already see the bruising that's a little bit indicative of what we're going to find. So that's in the subcutaneous tissue there at the inferior aspect of the incision. You can see that dark bruising. We have a couple sequences of this as we come down. Dr. Dimar, one of our faculty, is spectacular at recording some of these things as we do them for teaching cases. So you can see as we go a little deeper down here, we get to the fascia. That opening that you can see there, that transverse opening, is actually a full thickness tear through the fascia, through the posterior elements in a transverse fashion. So when we do these exposures, we're making a vertical incision down over the spinous processes that essentially forms a cruciate incision through the patient's fascia, through their posterior elements there. And when we get into these tend to have a large Morale Lavallée injury. So these are people are oftentimes delaminated clear around to their flanks. You can move your hand through there, showing just how severe these flexion injuries are and some of the techniques we have to deal with when we're doing these. So once he was exposed, this is what we were looking at. You can see the posterior band completely disrupted. You can see that we've actually taken out some of the posterior band there where that gap is, because it's mostly closed down from our reduction, but we used a ronger to remove some of the pieces there that were impinging. And you can see just how unstable that is. This is kind of just a summary of what we had as far as the injury there. And here's the construct we opted to do. Given that the injury was largely posterior band, we just went 2 up and 2 down. This is a 30-year-old male, good bone stock. And then in this case, since we didn't feel like there was a significant rotational component, we put in a cross-link rather than opting for the 4-bar construct like in the previous case that was more severe. So this is our final construct you can see there. Here's our intraoperative, postoperative films. You can see we pulled back T12, so that enterolisthesis is basically gone. And then here's upright films while the patient was still in the hospital. A couple of things to note on this one, and the reason we included it is we oftentimes will put in multiple drains in these people, not just a deep drain, but we'll also lace a drain or 2 into that Morale Lavallée injury, because that's something that we need to keep the fluid from building up in. Otherwise, we'll end up with a wound injury on top of this. But kind of just an interesting case to show how much of a soft tissue injury is involved with these.
Great job.
It's Neil again. Great case, guys. This patient was neurologically intact, right?
Yep.
Correct.
So would there be any thought of doing this completely percutaneously? Line it up exactly like you guys did. It'll reduce exactly the same way. No fusion. Take the rods out a year later. Take the hardware out a year later.
Well, I did this case too. We decompressed him. He forgot to mention that there was bone debris, and a lot of times the ligament flabrum rolls up like a window shade inside the canal. and we took off that edge of ligament and flavum from both bones, widened it, took out loose debris. I think there was broken facet and everything. I would find that extremely difficult to do with a percutaneous procedure. I do think, like with a chance injury where it's bony and there's the canal's intact, that I agree, Neil, that probably a percutaneous way is a way to go if you're good at it, but not on this injury. This was too unstable. I mean, you really need to, you can't take a chance of leaving debris in the canal, or when you reduce them, a lot of times the ligament flavum will flip into the canal, and we've had people get some neurological problems afterwards. So that was one of the big reasons we opened up too, because we needed to decompress the canal.
Neil, I think if it was a kid and you could rely on some ligamentous healing, might be a good choice, or more of a bony injury. But with that much ligamentous injury, I don't know that a year later it would have a level of stability where you'd be comfortable letting them go back to activities. Probably sort of a lesser ligamentous injury where you get more bony healing.
No, that's fair. I think with that ligament injury, probably we attempted just do a local fusion at the fracture site, but also get a screw into the fracture level just for stability, get another screw into the fracture level. And I agree. I've been just like you guys, open always, right? More and more got used to percutaneously reducing these neurologically intact patients with monitoring, of course. No, all good comments. I agree. It's one of those things where we're clearly pushing the envelope and been successful in quite a few so far, but it's just a thought process that's evolved over time of doing these perk and then removing the hardware. If you can trust the patient, that's the other thing. You got to trust the patient to come back to take that hardware out, do a local fusion at the ligament level.
Which we all know, Neil,
that's
trauma follow-up is kind of impossible.
I agree.
They all go somewhere else.
Fair enough. There's many factors involved. Agreed.
John, quick question. I was just a little surprised you just went 2 above and 2 below. I agree, trying to save lumbar spine below, but one more level of fixation proximally, and with a thoracolumbar multiplanar injury would be more standard, I think. You're taking a little bit of a chance. And how much do you fuse? How many levels do you formally fuse posteriorly?
I can't remember specifically, because as you can tell, these may all blend together in my old mind. But he had extraordinarily good bone. A lot of times I'll upsize to a 6.0 rod, mainly when I have a fellow there, because they're the only ones that can cut them. And or I'll do an outrigger like I showed before. But in this particular case, it seemed to me that there wasn't a lot of rotational instability, which is what really bothers me. It wasn't translated. It was just kind of a flexion injury. And I think we had pretty good stability. But you're right. I mean, you can certainly, if there's any question, and particularly in older patients that have soft bone, you might want to consider going 3 levels above and below, which I really do a lot of times. And or if they've got osteoporotic bone, maybe using some HA-coated screws, or you can use augment with cement. But, we try to do these cases in sub 3 hours at the most. And because you don't want to keep these people long on the table. A lot of them have polytrauma. So we can open these up pretty fast in an hour. And with the O-arm, in particular in the thoracic area, we can get screws in very accurately, very quickly, because it's a 15-minute spin. So you're right. Yeah, I probably should have done that, but I think I'm not sure. I just wasn't, you probably didn't have a lot of rotational instability.
Nice case.
All right. Great job, Kyle. Thank you very much. And our final fellow presenter will be Dr. Hans Zhang. Hans joined us after doing his residency at Duke, and he is going into private practice in Chicago with the Barrington orthopedic specialist in Chicago. So go ahead, Hans.
Thanks, Dr. Djurasovic. Thanks for everyone for having us. My case is a 67-year-old that presented to ED after falling while drunk onto a curb. And his main complaint in the ED was really just severe back pain without any other injuries. As you can see there, neurologically intact with a normal neurologic exam, significant also for a BMI of 42. His trauma workup showed a hyperextension type injury, as you can see here, which is a little bit different from the flexion injuries that we've seen, but also quite extensive ankylosing spondylitis crosses thoracolumbar spine, as you can see there, with a 3-column disruption and also frank displacement of the fracture at the T10-11 level through the disc space there. Some of the considerations that were had preoperatively in terms of the planning and the positioning was that this hyperextension injury, definitely we wanted to make sure there were bolsters and adequate support to avoid exaggerating the injury like typically would be on a Jackson table without any kind of supports at the fracture level. And then also you can see on the CT scan here preoperatively that as is common with these AS patients, there's quite a substantial degree of osteopenia and poor bone quality. So I think that affects the consideration of how many levels that you want to go, and also the type of fixation that you want to have. Also, particular to the thoracic area, you can see there on the intraoperative X-ray at the left there how challenging it can be to get adequate X-ray imaging on a large morbidly obese patient, also with thoracic also with osteopenic bone, osteoporotic bone, and also in the thoracic region. So this is, I think, a case where it demonstrates the ability of O-arm and stealth to not just plan and help navigate screws, but also to critically assess your reduction and make sure that anything less than perfect isn't accepted in terms of reducing the fracture and making sure that gapping anteriorly doesn't persist. So here's a video, I think it will play here, of the screws going in. This is a fairly familiar video. No. And I think one of the other things to appreciate is just the amount of soft tissue at the thoracic spine on this patient. See here. So these are the intraoperative pictures of the reduction itself. As you can see, once the patient was positioned, he did have very satisfactory reduction of the fracture in both the coronal and the sagittal planes here. You can see another picture there of the level of the mark there, and there are the levels affected there. So here's the intraoperative CT scan from the O-arm that you can see there's still a little bit of persistent gapping, which we were able to reduce our instrumentation and hardware there with supplemental rods on either side of the construct and bone grafting all the way through. And these are his immediate post-op films on the hospital, showing that the gapping anteriorly is nicely reduced. The screws are nicely in place, and the patient did well, neurologically intact as he was when he first came to us. I think that's it.
Great. And the O-arm, the other thing about these ankylosing patients is oftentimes the normal landmarks you use for thoracic pedicle screws are obliterated because it's just a sheet of bone in the back, especially the AS patients. So navigation is really helpful in these cases too, in terms of putting your screws in the right place. Very nice job, Hans. Thank you.
Thank you.
This is Izzy again. One question about the Ank spawn patients. Did you guys do any kind of laminotomy or some kind of decompression in the event that he develops an epidural hematoma at some point later? Is that a consideration?
We did not do any laminotomy. 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 We did not do I think that it definitely is a consideration preoperatively, and I think I can't remember if this patient had an MRI or not, but we commonly get MRIs preoperatively and rule that out to make sure there isn't a compressive etiology that we worry about. I think this patient preoperatively was completely neurologically intact, so I think the thought is decompression and whatnot in terms of the goal of the surgery was for stability, not to improve neurology.
Do you think that a laminotomy or even laminectomy would be prophylactic for that? Right, because we see sometimes patients who come back, after just standard lumbar procedures with epidural hematomas, and they've had laminectomies, and it didn't really prove to be preventative for developing that. I'd never thought of it as a prophylactic tool.
Yeah, I would do that in the Ank spawn patients because they're so unpredictable. As was pointed out, their bone is very porous. You're poking holes through it. Their dura also tends to be sticky. It sticks to the undersurface of the lamina. It doesn't peel off very well. They frequently tear. So if you develop an epidural hematoma, it doesn't have anywhere to go. So that's why in that group, the delayed hematomas are something that we've seen. You don't know how to explain them, but I think leaving an outlet may avoid a disaster for you, particularly in the cervical fracture dislocations or cervical thoracic junction dislocations.
Yeah, I kind of agree. This patient, when they crack like this, they actually can drain anteriorly out the front and drain posteriorly through the crack. And I have not seen a operative patient develop a postoperative intraoral hematoma. I have seen patients we've had that came in a lot of times delayed a day or two. They came in and developed a hematoma that we had to decompress. But have you seen people that you've operated on and develop a post-op hematoma that was consequential to them?
Two in particular that come to mind were cervical thoracic junction fracture dislocations.
Yeah, I might find that more in the cervical area. That would definitely
that
be
were
a little bit more regional.
Yeah.
Anyway, interesting thought. We ought to do a paper on it.
Yeah, one question that I had, so great cases, really well done. I've seen the O-arm used a lot there. So on your incomplete patients, talking about neurologic deficit patients, do you get a formal CT afterwards, or do you rely on the O-arm to kind of see how well reduced and decompressed they are?
I personally will sometimes do. I'm fairly comfortable with the new generation of O-arm. I think they're fairly accurate, and we always palpate and guide the screws. If I'm a little concerned, I'll actually do an intraoperative O-arm to make sure everything's, and then I probably would not do a post-operative one. But often I will do it to check for fragments, to check for reduction, to make sure I didn't leave any fragments of bone in, to see where the screws are. So I think that's a worthwhile thing to do. I try to count my exposures because I don't want to overexpose people. CAT scans burn people up pretty effectively. And so I try to limit them to, no more than 2. Like on that last case, the reason we were putting the screw in manually was he's a big, tall, gigantic guy, and we just did one O-arm spin. And the bottom screw, because he had gigantic pedicles and we had TPs to guide them, we just put them in manually. So that's an example where would just try to do one spin, for example, Jens, to save on radiation exposure.
Yeah. So I guess I do a little bit. I don't generally O-arm them unless I have trouble putting the screws in. So most of the time I would freehand them if they have decent pedicles, and then I might be more inclined to do a post-operative scan. But really, if I'm worried about their neurologic status, I guess I'm more likely to do an MRI afterwards than CT, maybe.
And see what?
Let me throw a question at you guys. I'm dealing with a case as an expert witness on a case that had a misplaced screw, O-arm in the hospital, did not use the O-arm, and that doctor is being sued. I'm actually expert. I think it's ridiculous, but I'd love to know your opinion. The O-arm was there, and the case is basically, why didn't he use an O-arm post-op? And that's below the standard of care. But obviously, I'm going to defend that. I just wanted to know what you guys' thoughts are. Because this is a dangerous path we are leading ourselves into now with this OARM. And I'd love to know what thoughts are. We got to come to some consensus on this. Are we obligated to do an OARM just because an OARM is there? I don't think so, but I'm love to know your thoughts.
Well,
Go
yeah,
ahead,
I
John.
mean, I just think that it depends on where you're doing your surgery. I shudder when I do screws at T5, 6, 7, 8, because the pedicles are often so small, even in gigantic individuals. And I know that those particular areas probably are better suited to use guidance. And I shudder to think how many screws are out that haven't been discovered. And, you know, but if you're down in an area where you have large pedicles at T10, 11, and 12, well, I don't think it's a standard of care remotely there. So my honest opinion is I think people are becoming more dependent on it. And I think that someday it may be the standard of care within a decade. Some sort of guidance.
They're kind of reaching kind of medical legal threshold here. It's kind of sad though. It's sad we're getting there. That you're kind of getting, the lawyers are all over it, that you're obligated to do an OARM now because you got one. Post-op, post-op.
Yeah, a misplaced screw isn't malpractice. A misplaced screw with consequences it could be.
Yeah.
It's different.
As you said, it's a slippery slope because not every hospital in the country has access to an OARM. So the next step is to sue a surgeon because he operated, in a hospital without an OARM. So
exactly, it's a horrible place we're in right now.
It goes to a bad place.
Well,
yeah,
it's a bad place.
The other thing that's a problem is that if you just use guidance all the time, right, whatever the brand may turn out to be, all right, then when it's not telling you the right thing, you don't recognize it. And I think that people trained on nothing but navigation are relying that it never makes a mistake. And any of us who use navigation know that's just not the case. And recognizing when the navigation isn't telling you the right thing is incredibly important and is going to be a lost art at some point.
I mean, we've got such big brains out here. The question is, should we have a consensus statement on that? I think we're going to deal with more of this as time goes on. And maybe we as a society have some consensus statement on this.
Well, Steve really stated the defense for this, with what he just said.
Right.
Because you can miss things with the OARM too. And you get knocked out of registration and all of a sudden your assurity goes way down. And so we've all had that happen too. So, trust but verify.